Okay, we're about to be ready. Charlie, I just want to remind you in our, I have a lot of links for you to put in the chat today, and those are highlighted. And we're, oh, we've already let people in. Okay, excellent. Hello, everyone. I'm going to go ahead and start the live stream. Just a second, I'm going to do that. Charlie, I think you might have access to starting the live stream on your side. Because you joined as public affairs. There we go. We're going to give that 15 seconds and we'll get started, everyone. Okay, it is 7 p.m. and we will get started. Good evening and welcome to UT Southwestern Science Cafe. We're so glad to be back this fall and we're pleased to see you online this evening. My name is Jenny King and I lead the UT Southwestern Public Affairs team and our Science Cafe program along with Charlondra Thompson. On behalf of my colleagues in Public Affairs and in the Peter O'Donnell Jr. Brain Institute, as well as our guest faculty speaker, Dr. Carlos Bagley, thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into the science of healthcare. As an academic medical center, UT Southwestern brings research, health education, and patient care into one institution. This evening, we are discussing the science of robot-assisted spine surgery with Dr. Carlos Bagley. More on him in just one moment. Before we begin, I have a few technical points to share. First, we are recording this program and live streaming it on our UT Southwestern Twitter page. Go ahead and mute your microphones to help with the audio clarity for all. Second, we encourage you to leave your video on so we can see each other, and especially during the Q&A portion of our program. And finally, just a reminder, while we cannot answer personal medical questions, we welcome your general questions about robot-assisted spine surgery. Please list those in the chat. Also, before we get started, I wanted to share that UT Southwestern is hosting a community event next weekend on Saturday, September 17th, and we invite each of you to RSVP and join us at our newest ambulatory clinic, UT Southwestern at Redbird, which we officially dedicated earlier today. Charlie will put the invitation link in the chat so you can click through and read all about it. We know it's going to be a great day. And now I'm so pleased to introduce our guest speaker. Dr. Carlos Bagley is Professor of Neurological Surgery and Orthopaedic Surgery, Director of the Neurological Surgery Spine Program, and leader of the Multidisciplinary Spine Center at UT Southwestern Medical Center here in Dallas. Prior to joining UT Southwestern in 2015, Dr. Bagley was Director of the Spine Center at Duke University Medical Center. Dr. Bagley received his undergraduate and medical degrees from Duke University and completed an internship in general surgery and a residency in neurological surgery at Johns Hopkins, where he became chief resident. He also performed his fellowship in spinal surgery at Johns Hopkins. Dr. Bagley's research focuses on improving patient outcomes. Please click on his bio link that Charlie is also sharing in the chat and learn more about his remarkable career and his positive impact on patient care and outcomes. Dr. Bagley, thank you so much for joining us this evening. Welcome to Science Cafe. The virtual podium is yours.
All right, thank you very much, and I appreciate the opportunity to speak here tonight. As has already been mentioned, my talk tonight is on robotics and how we're using that technology as well as some adjacent technologies to improve the care that we provide to spine patients. And so with that, we'll go ahead and jump right in. So just to give a bit of an overview of the talk tonight, we'll start with a little bit of the history of spine surgery. In order to know where we're going and where we are, it's always important to know where we've been. And so I think a little bit of history it gives a bit of context. I'll go through a little bit of why the impetus and what the need for robotic surgery and how it's helping to fill a void in care, and then some of the outcomes and efficacy as we understand it in today's day and age, and then some future directions of additional technology such as artificial intelligence, augmented reality, virtual reality, and how that may play a role in the future of spine care. So to start, spine surgery has its roots back in the antique period. So back in the 4th and 5th century BC, that was when the first descriptions of the normal curvature of the spine date back to actual Hippocrates. Aristotle was the first to describe the kinesiology or movement of the spine, as well as some early biomechanics of the spinal column. And then we also had in the 7th century AD, the first laminectomy procedure, which is a procedure in which we remove a portion of the spine to decompress nerves and things like that. And that has its dates back to, again, the 7th century AD. In the early 19th century, really spine surgery consisted of that simple laminectomy. Had not been over the centuries much in the way of advancement at all. And the laminectomy was considered the only surgical approach for pretty much all spinal pathologies, whether it was a tumor, infection, trauma, it was a one-size-fits-all. At the beginning of the 20th century is where we started to see the understanding of spinal deformity. We started to develop some non-operative treatments for the spinal deformity, such as the rack and the traction devices that are illustrated there in the pictures. And so we kind of had a little bit of movement, but really still spine remained in its infancy. The first descriptions of outcomes with spinal surgery were actually quite grim. If you look back at some of the reports back in the early 19th century, the first thoracic laminectomy for a fracture dislocation was reported back in the early 1900s. The first case series of laminectomies for spinal dislocations was reported in the literature with a 100% mortality rate. So needless to say, we had a lot of room for improvement at the time. And that was not just surgically related, that was also related to the anesthetic limitations of the time period. It wasn't until 1829 that the first successful laminectomy was published in the medical literature. And from that time, we've seen a fairly rapid evolution of techniques and treatments for spine, starting with simple wiring techniques to try and stabilize regions of the spine, onto Harvey Cushing performing the first spinal cord tumor or tumor within the substance of the spinal cord being removed. And then here more recently with approaches to the spine, to the front of the spine, or what we refer to as anterior approaches, various approaches through the side, various devices, as well as new techniques culminating with robotic technology here in the past few years. Commiserate with our advancement in technology, our understanding of the normal spinal column alignment and biomechanics has also advanced tremendously over the years. Understanding how the normal alignment of the spine, what we should be and what our goals should be as we're attempting to treat patients with various spinal conditions. And this has been really the foundation of how modern spine treatment is performed nowadays. that has led to a renaissance of treatment options, from ways in which we can completely reconstruct the spine from top to bottom, motion preserving techniques such as artificial disc and disc arthrodesis, minimally invasive techniques where we're able to perform very complex procedures and tumor removals through centimeter-sized holes, and again, just a renaissance of technique and advancement in the care of patients with spine conditions. With that, however, that we've also seen a skyrocketing rate of fusion procedures performed throughout the country. Again, this slide is a bit dated now, but the trend lines still continue, where we've seen rapid rises in the number of fusions that have been performed, some of which is a result of advanced technology and our ability to treat things. But then also that has been coupled with a dramatic rise in costs associated with spine care and with healthcare in general. If you think about it, really about 20% of our gross domestic product here in the United States is dedicated to healthcare, and a significant component of that is related to spine. So despite those dollars being spent, we may not be getting our best bang for the buck. With this study here published in the early 2000s or in the mid 2000s, it indicated upwards of almost 90% of patients experience one or more complications during their hospitalization following a complex spine procedure. Many of these were post-operative, so 3/4 of these complications were after this patient had left the operating room, but a significant proportion related to the actual execution of the surgery itself. And so some might ask, well, we've seen all of these minimally invasive techniques, and we're able to do surgeries now with a Band-Aid on the back and things like that, and we've eliminated all of that. And not necessarily. Again, this study here looked at the body of literature and compared open procedures, or the traditional surgical approaches, as well as minimally invasive approaches and hybrid procedures where we used kind of combinations of both, and looking at the overall complication rates. And as you can see from the table on the screen, the complication rates overall from the open and minimally invasive techniques are pretty similar. And as the procedures have become more complex and we're deploying these hybrid procedures where we're using kind of tools from all of our toolkits, the complication rate is even higher. And so although we've made advancements, we haven't quite cracked the code yet. And that has led to the question of the value of spine care that we're providing. And when we talk about value in healthcare, we talk about the outcomes that we're achieving, as well as the experience of the patient undergoing the treatment per dollar spent. So how much we're investing in achieving those outcomes. And again, with the results that I've shown you, it has demonstrated that at times we may be missing the mark. And so as we do in healthcare, we've kind of shifted our focus and focused less on the recovery room and more on our room for improvement. So looking for opportunities to improve the care that we provide, and looking for new and innovative ways in order to provide treatment. And that has led to the emphasis and the growth in robotic techniques and the interest in robotic surgery. Robotic surgery really has its roots back in the early 1900s, when we first started using the stereotaxis for brain operations, actually, to access deep areas of the brain. From there, as we've developed new imaging techniques such as intraoperative fluoroscopy, where we're able to use live X-ray to look inside the patient, onto intraoperative CT and very high resolution three-dimensional imaging techniques, that has all been incorporated into these new technology platforms, and has allowed the robotic technology to advance to the state that it is now. We've also seen a tremendous growing body of literature on the subject. Again, if you go back to the 1990s and early 2000s, if you look at the literature on robotics and spine surgery, you would have to look pretty hard to find any material information out there. But here in recent years, you can see a virtual explosion in the body of literature on robotic surgery, the pros and cons, the ways in which this technology can be utilized to help patients. And so we're learning very rapidly about this technology and how it can help us do better at our craft. And so as we talk about robotics, one thing that's important to remember is when we use the word robotics in the classic sense, it is a machine that's performing a complex task autonomously. And that's really not what's done in the spine realm. So what you will not have is your doctor in the cafeteria with a remote control controlling the robot while you're having surgery in the OR. That's not robotic surgery. And really the robotic platforms for spine, they are more of what we refer to as a cobot. So they help assist the surgeon, but they do not do the work for the surgeon. And there are a number of different robotic platforms, but in general, they all have some sort of reference array, which allows us to localize the equipment that we have. The equipment that we're utilizing, whether it's a drill or a screw, has also a reference array to allow the eye of the machine to sense where it is in space, and that is merged with preoperative imaging, intraoperative imaging to give us essentially a real-time picture inside the patient, so that we can line up these devices and place things with the robot. So the robot aligns the shot, but the work is still done by the surgeon. So the robot assists us in doing our work, but it does not do anything related to the patient without the surgeon actually carrying out that task. So very important to remember that. That's very different than some areas of robotic technology where there is more of a kind of a remote control type of robotic arrangement with the device and the surgeon. But in spine, because of the proximity to the nerves and the blood vessels and very delicate structures, and the challenges around haptics or the tactile feedback with robotic technology, we still haven't advanced to the point quite yet where the robot's able to do these autonomous tasks safely without the human controlling that.
Dr. Bagley, we have
Yes,
an audience poll question that I think was supposed to be earlier, but it might be a good time to launch that first one. Would that be okay?
Oh, yes, ma'am, absolutely.
Okay, Charlie, you're going to need to launch that for me. Just click on polls. It's very relevant to what you just were saying. And if it's not going to work, we might just go on. Charlie, what do you think?
Yes, I've launched it. And so
Okay.
if you all can't see it, then we may be having technical difficulties.
I think we are. I'm so sorry. Oh, let's go ahead and continue, Dr. Bagley. I will not interrupt again.
Actually, I think the poll did come up. I saw it.
Oh, good. The host can't see it, so everyone please answer. And we'll close the poll in just a couple seconds.
Okay, I've ended the poll.
So, with that first question regarding where robotic technology is currently in use, it is actually all of the above. Everything from the auto assist in terms of what's it called? The self-driving cars. I'm blanking on the term right now. Autopilot essentially is the computer or the robot driving the plane for the majority of your flights. It's used very routinely, and it's revolutionized prostate cancer surgery and things like that. So robotics are really integrated into our lives in areas that we may not understand or appreciate, but they're working behind the scenes for many of the things that we do now. So back on the subject of robots in spine specifically, so really the potential benefits of the robot for spine surgery falls into 5 potential categories. Our ability to plan, our ability to do things accurately, our ability to do things safer as it pertains to radiation exposure with some of the technology that we currently use in the operating room, as well as the potential benefit on outcomes and efficiency and cost effectiveness. And we'll kind of go through each of these points here and some of the literature behind it. So in terms of planning, the robotic platforms are wonderful in the sense that they allow us to really plan three-dimensionally the exact procedure from the trajectory of each and every screw that we're going to place at each and every level. We can plan what are called osteotomies or bone removal to reshape the spine when we need to place interbodies in the disc, where we replace the disc to, again, help to realign and reshape the spine. It allows us to do all of that and plan that out very precisely, essentially in our office before we ever enter the operating room. So essentially you get a trial run at the surgery to plan it all out. In addition to that, the artificial intelligence behind that drives many of the robots will also tell us the feasibility of our plan. And so when we've essentially tried to correct more than the body will likely tolerate, the machine will alert us to that. And it, again, will help us to modify that plan so we can execute it in a more safe and feasible fashion for the patient. And again, it takes us from the ability to look at things in two dimensions, as you see on the left there, to really a three-dimensional representation of what would be the anticipated finished product, as we see there on the right. And when we look at the literature behind that, how effective are we at planning and following through on that plan? As you can see from the table there on the top, the differences between the planned procedure and the actual the results in terms of the curvature, both in the coronal plane, which is what we do to correct scoliosis, as well as the sagittal plane, which we do to correct kyphosis, is pretty good. And so again, not perfect, but our ability to plan and then follow through on that plan is quite robust with the robotic technology. It also, in terms of the planning, where we place things. Again, this study here out of Johns Hopkins, published here recently, has shown that we're accurate to up to 1 millimeter with screw placement. So less than a quarter of the diameter of the average screw is the level of accuracy that we're not only able to, again, plan, but actually follow through on that plan to that degree of accuracy. The other aspect of accuracy not only is placing it where we want to place it, but placing it safely in a safe location. And what this study here looked at again, systematic review of the literature, and the authors concluded there for every 11 screws or so that we placed using the neuronavigation and the robotic technology, based on the average breach rates and malplacement rate, for every 11 screws that you place using this technology, you're able to prevent 1 screw in a suboptimal location. Again, the disclaimer there is that this is an average, and so some surgeons are more facile and as with anything, more accurate with the current technology. But on average, this is allows us to do our planning and execution of the plan in a much more accurate fashion. As I mentioned earlier, radiation exposure, the poll that we put out earlier, there are a number of risks that are posed to the staff and the surgeons because of the years of radiation exposure from the current technology. That includes an increased risk of cataracts, increased risk of thyroid cancer, and things like that from this constant radiation exposure. And the robotic technology, because of the way that it reduces the number of shots and X-rays that you have to have, it dramatically reduces the exposure to the surgeon, to the hospital staff. And so from an occupational health standpoint, it's a much more advanced technique for the team. The question of radiation exposure to the patient, although very safe, and for the average patient, the dose is well below anything that would be of any concern. With the way that we're able to plan and use some intraoperative or preoperative low radiation CT protocols, that also helps reduce the radiation exposure to the patient. So again, allowing us to increase the safety of the work that we do. As far as outcomes are concerned, the results there depend on what outcome you're looking at. So for example, if you look at operative time, on average, the operative time, including the planning for the robotic cases, tends to be a little longer than the traditional case. Also, because this is new technology, and as with any new technology, there's a learning curve, and that learning curve can be as great as 30 cases to get facile with this technology. And so that's important to remember. You just don't pick up a machine like an iPhone and it works seamlessly. There's a learning curve where you have to kind of learn the strengths and weaknesses of this technology. And so us surgeons have to understand that, and that's something that we closely monitor. But given the improved accuracy of the screws, the reduced incidence of what we call facet violation or disruption of the capsule around the top joint of a fusion, it can lead to lessened incidence of breakdown of the levels next to the surgery. And so by deploying these technology, you can potentially save future surgeries. And so that adds to the value that this technology can provide. Even though you're spending a little bit more time in the OR on the index surgery, you are saving potential downstream time and surgery and revisits to the OR. As it pertains to outcomes, what we refer to as patient-reported outcomes, such as the pain scales or the ODI, which is a measure of disability that patients have related to their back condition, those have been found to be fairly similar to other techniques. So therefore, we haven't seen the benefit there yet, but the benefit in other realms is emerging and becoming more apparent as we get more experience with robotics. But again, as with anything, it's important to remember that this is an emerging technology. And so there's a point at which you gain proficiency with this where the outcomes and the execution is much more facile. And I would say with robotic technology as a field, we're not quite there yet. And so important to remember as we temper our expectations regarding robotics here in 2022, we want to remember that, but this is something that will play a vital role in the care that we provide for patients going forward, and will be allowing us to do increasingly complex things very safely. Regarding the finances of this, one thing that's important to remember is that these robotic platforms are not cheap. They can range anywhere from $500,000 up to $1.5 million for the equipment itself, and that doesn't include the disposables or the parts of the device that are used for a given case that are not reused, and that can run $2,000 or $3,000 per case. And so again, that's something that has to be factored into how we value or how we measure the cost effectiveness. That being said, again, looking at the literature, this study here published out of Louisiana, they looked at their center, assuming the rates of infection and revision surgery being lower as they had found with their early results. If they extrapolated that out to transitioning 3/4 of their surgeries using the robot in minimally invasive surgery, they anticipated that they could save a little over $600,000 a year. So there is potential cost effectiveness here, but when you look at the body of literature as a whole, it's a bit more mixed. So this table here is looking not only at robotic surgery for spine, but also robotic surgery for other conditions, so prostate, colectomies, hysterectomies, et cetera. And as you can see, the bubbles towards the bottom are the studies that indicate the favorable cost effectiveness. The ones in the middle demonstrate the lack of cost effectiveness, and then the ones on the top are unclear. And so you can see the results there from a cost effectiveness standpoint. It's a bit mixed, and so we're still that's still being adjudicated to some degree. in addition, as with all technology, technology is not infallible. You know, as they say, to err is human. But as we all know, for those of us that have spent a lot of time on computers over the last couple of years doing Zoom meetings and things of that such, computers can have gremlins in them as well. And so I'll, as an example, this short clip that I'll play for you, this is Volvo, which we all are familiar with, very well-respected company, displaying their new auto brake assist technology for the world. So this is the example and demonstrating how safe this technology that will stop a car and prevent it from hitting an object. And so this is their essentially the robot.
Cuidado, José, cuidado, José. Sí, aquí es mejor.
Okay, so fortunately he's fine. However, again, it illustrates the perils of robotics, especially in a field like spine, where, as I mentioned earlier, there are very critical, very sensitive, very delicate structures, such as your nerves and your spinal cord, in very close proximity to where we're working. And so that's why really in spine, we have more of an assist from the robot versus an autonomous actions of the robot performing these complex tasks in these very delicate areas. One of the other potential concerns regarding robotic technology, and what we refer to in medicine as enabling technology, is what it does to our learners. And so if any of you have seen this video, I apologize, but I think this kind of illustrates some of the points of the plus and minus of technology. This is a video from a couple of years ago looking at kids, and essentially a bunch of kids were given a phone, a dumb phone from the 2000s, which I'm sure all of us are familiar with. And so this is the next generation trying to figure out a dumb phone.
I have the iPhone 7. An iPhone 6. I usually use my parents' phone, like my dad, my mom. Wow, I have no idea what this is. It's kind of weird. It's the tiniest screen I've ever seen. It looks like a calculator. My grandpa has a similar phone to this. How do you turn this on? I'm confused. Huh. Do you have to charge it or something? Oh, up here. Oh, I got it. I turned it on. Oh, it's not on. How do you find games? I can't find the games. Okay, that's not it. Profiles, clock, reminders, calculator, games. There's Snake. Space, impact. How are you supposed to play the game? Oh, like, you can't touch it. I don't like it. Game over.
Okay, so so needless to say, one of the concerns as a teacher and as an educator, how not only we us old fogies in the field adapt to this new technology, but also how our learners and the next generation of surgeons are not essentially handicapped by the technology, where they can't do other techniques and understand the anatomy and things like that, because they become so reliant on robotic technology. And so there is always that proverbial double-edged sword as it pertains to technology, sometimes oversimplifying or I guess handicapping us a bit.
I have.
Oops. So the other concern that we have is the hammer and nail phenomenon. And so robotic technology, it's very accurate, it's very easy, and when you have a hammer, then everything looks like a nail. And so you worry about the overutilization of the technology as well. And again, it's something that we have to be mindful of as these technologies become more nimble and more facile. It's not for every condition, it's not for everything, and it doesn't cure all evils. And speaking of all evils, what the other thing that it does not cure is the human aspect behind this. And so your robot won't make your doctor a good person if your doctor's not a good person. And so there's always the human aspect behind this, and that can't be underscored enough. This doesn't cure all evils. It doesn't cure all back pain. It doesn't cure all spine conditions. But it is a very effective tool in the right hands that can be used to help a number of patients. But again, there's still the human factor behind all of this. In regards to the future applications of robotic surgery, it's phenomenal. And as the technology becomes more facile, we're able to do more complex reconstructions, more complex planning, able to treat more difficult conditions with this robotic technology. And again, increasing the safety for even these most complex, kind of the 1% of cases that we treat in the field. We'll be able to deploy this to help assist us there as well. It will also allow us the ability to access areas of the spine and areas of the body in ways in which we could not before. This is some recent reports of a case series where using this, what's called Camden's triangle, which is this small area which can be about a centimeter or so, to access the disc space and allow us to, from a small oblique approach, using the robot to safely do anterior work in the spine. So approach the spine from the front in a very slick and very nimble way that would otherwise, again, be much more challenging with the current visualization techniques that we have. In addition, the future of robotics is also allowing the robot to do some of the tasks that currently have to be done by a human. There's work underway in the lab to develop the robot such that the tactile feedback allows us to utilize the robot to drill in very delicate places, again, within a millimeter or so of a vital structure, such as a nerve root or a cranial nerve. And so in the future, there will be more of some of these more complex, delicate tasks that can be safely performed by a robot. And we are trying to develop those techniques as we speak in the lab. But technology in the spine realm and in medicine isn't limited to the operating room and to robotics. We're also using a number of data analysis and artificial intelligence techniques in order to improve healthcare in tremendous ways. This includes more robust data analytic techniques from machine learning techniques such as supervised or unsupervised learning, to our ability to process natural language and voice recognition to inform and enhance the decision-making process. And this is a feedback loop in which we're able to extract data from the electronic medical record. So for all of you that have been to your doctor, the EMR, whether it's Epic or Cerner, it has a tremendous amount of data in there, but most of that data is in free text notes and things like that your doctors have written. So these data analytical techniques, this AI, can help process those and transform those into data formats that can then enrich the machine learning techniques, which can help us improve our ability to screen, diagnose, as well as to treat patients. In addition, we're also using what's referred to as augmented reality. And so for any of you that have recently remodeled your home or bought a new couch or rug or anything like that, you may be aware that you can go onto your various sites and you can look at what the rug or couch looks like in your home. That same augmented reality technology is being utilized in the operating room to allow us to essentially see inside the patient. And so it's able to project these three-dimensional images onto the head display that we have in the operating room, and again allows us to use this technology in a way to use minimally invasive techniques and visualize, again, the inside of the body without actually having to open up the body. This also, the advantage here is that the cost for this type of technology in general is far less than it is for the robotic platforms. And so it will allow us some of the same technology, same techniques to be utilized more broadly without the high cost of investment up front. This is also a spectrum. So augmented reality is kind of the cousin of what's referred to as virtual reality, which is more this immersive artificial environment. Currently, virtual reality is more utilized in the teaching realm and in some therapeutic realms. And then there's what we refer to as mixed reality, where there's the merging of the augmented overlaying of the hologram over the physical world and this immersive experience. And that is used in a number of different ways throughout healthcare. It can be utilized for live feedback during actual surgery, telementoring. So, you can phone a friend from across the world to join you in the operating room for a complex case. Navigation, tracking, rehabilitation is really utilizing these techniques to help rehab patients from strokes or surgeries or traumatic brain injury. It's also a tremendous tool in educating not only our learners here at the hospital, so future doctors, nurses, and other healthcare professionals, but also to educate our patients regarding their own condition and help our patients be better advocates for themselves as they migrate the health space. This will also lead to the eventuality of semi-automatic or remote surgery. And you can envision a surgeon performing a complex procedure on a soldier that's injured in the battlefield from across the world. And that will at some point be a reality, but right now we're on in the first stages of that essentially revolution. And this type of technology is not limited to the operating room. These are some robot nurses that have been deployed in various facilities around the world. COVID, as we've all experienced here over the past couple of years, has led to a number of strains on the healthcare sector. And these robotic nurses have been deployed to decrease the burden on the clinical staff within the hospital, and also in areas where protective gear is more limited. And so allowing us to render care safely and expand the ability to care for patients. And so again, robots are not just for the OR, they're also for our treatment of patients outside of that. And this will all eventually lead to something that seems like it'll be out of a Marvel movie, where we're able to construct, deconstruct, explore a patient's insides from across the world, plan, replan, revise, so on and so forth, which will allow us to advance healthcare in a way in which we can be more predictive about what may happen, proactive in terms of preventing it, personalized and getting down to the individual patient's needs, and in many cases preventing things altogether. And the goal of all of this is to bring a precision medicine approach to spine care, such that we can find that right piece to your puzzle to help get you back to health and help reclaim the quality of life that affects so many folks affected by spine-related conditions. And so with that, I thank you all for listening to me.
Dr. Bagley, thank you for your presentation. We will now begin the Q&A portion of this session and start with some questions submitted ahead of time, and then we'll address questions from the chat. The first question is, will robotic assisted surgery make the procedure more available?
So the hope is yes. So the procedures are available. I think that what robotic surgery will do, it will improve and standardize the quality of the procedure that's provided. And you take out some of the human error, because again, that's a spectrum. And with the robotic technology, you can close that spectrum down where the quality that's provided is much higher and much more standardized. So I think as the technology becomes cheaper and as we are able to utilize it more broadly, it will improve the care of patients, not just here in the Dallas-Fort Worth area, but really around the world.
Thank you. The next question is spine surgery typically one that has long-lasting effects versus a hip or knee replacement, which is effective for X amount of years?
So if you look historically, as I gave some extreme examples in the early part of my talk regarding the outcomes related to spine, it has evolved over time. The old notion was you have one spine surgery, you're going to have a half dozen. And that's not necessarily the case because, in the beginning, we were working with very rudimentary tools, but as these tools have become more refined, as our knowledge of spine biomechanics and how it interacts with the hip and the pelvis and other adjacent structures, our ability to execute surgeries that are more durable and more long lasting has improved. That being said, as I mentioned earlier, also to err is human, and so one of the problems that we run into as humans is that we feel good and then we do things that may not be good for us, and so how we treat our back is the one kind of aspect of this that is an ongoing dialogue and connection with your physician and your treatment team. So the surgeries are a part of that, but there's no substitute for the prevention of keeping yourself fit and the other kind of important aspects of good spine health.
Okay, thank you. One more pre-submitted question, and then I'll do a couple of questions from the chat. Is robotic surgery available for complex cases or just simple cases or all cases?
It is available for all of the above. However, it's the more complex cases, it's being utilized less than the more straightforward ones because, again, we're on the early part of that learning curve as a field. But there's a spectrum there, and there's many cases where there's a hybrid approach where the robot is used for some of the very complex, delicate tasks in a very intricate area, and then traditional techniques are used elsewhere. And so it is being utilized for even some of the most complex cases, but that is a minority of cases at this point, but will become more commonplace as we gain more experience.
Thank you. So Rich asked, what types of spinal surgery are you most likely to use robotic assistance for?
So at present, most robotic assisted surgeries are fusion procedures and things like that. So patients that have, whether it's instability of a portion of their spine or spinal deformity, such as scoliosis and things like that. However, we're also looking at ways in which we can use it for tumor resections and things of that nature. But that is, again, more of an emerging indication for it versus something that's utilized very routinely. But I would say at some point in the very near future, robotics will be used with pretty much in every aspect of the types of surgeries that we do. Cervical surgery or neck surgery is one of the later ones right now, but we're getting more accustomed to using it for that.
Thank you. This question is from Marion. Marion says, let's start with why anybody gets spinal surgery at all, and then why robotics?
So spinal surgery, as for any of you that have ever heard me speak, it is always the last resort when other things don't effectively treat the condition. And so the vast majority of folks with spine-related conditions will respond very favorably and effectively to non-surgical techniques such as physical therapy, pharmacotherapy with anti-inflammatories, or therapeutic injections and things of that nature. So the minority of patients that don't respond to those techniques that then continue to have pain that is significantly impacting their either function or quality of life, that's where spine surgery comes into play. Robotic surgery is not, again, it's not something that is a magic pill or anything like that. It's a tool that we use to execute a surgery. And so the real key is the appropriate surgery. And then if that surgery lends itself to robotic technology, then robots are great for that. However, if the problem or the surgical procedure doesn't lend itself to that, then the robot can actually be a detriment to an ideal outcome.
Bob asks, how is patient eligibility determined?
There's no hard and fast criteria as to who's appropriate for the robot and who's not. There are a number of factors that go into that. It depends on the condition, your anatomy, the capabilities of the surgeon, the facilities. There are a number of variables that go into that, and so there's no easy formula as to who's right for the robot or not.
Thank you. Our next question comes from Lisa. Lisa wants to know, are there limits with scoliosis surgery in addition to age, et cetera?
There's always limits to everything. We're always pushing those limits, however. Once upon a time, again, because of the limitations and the tools that we had, it was very difficult to correct scoliosis in an adult. Nowadays, that's fairly routine. Bone quality or whether there's osteoporosis or things of that nature is one of the limiting factors sometimes in correcting scoliosis. One of the other factors is overall physiologic health. Your overall ability to condition your muscle mass and things like that. Because when folks are very debilitated before a scoliosis surgery, it's very difficult to recover from that early on because it can be a very onerous procedure, even with some of the minimally invasive techniques that we utilize. So there's no absolute cutoffs, whether it be age, whether it be degree of deformity or curvature. It's dependent upon the team that that's taking care of you, as well as your own specific characteristics that can make the procedure favorable or not for a given circumstance.
Thank you. Our next question comes from Alicia. Is there a certification program for robotic surgery?
So there's no additional degree or anything like that. However, most of the, or I would say all of the companies that have the robots train the surgeons on the robotic technology, how to utilize it, what are the weaknesses of the system, what are the strengths of the system, how to utilize the various bells and whistles, the different tools, and they also train the staff at a given facility when that equipment is acquired, and they continue to provide ongoing education. There's also peer education. So we talk to other users of the robot around the country. And then as with anything that we do in medicine, we're always constantly learning. So when we attend national meetings and things like that, we continue to learn new techniques and learn from each other and teach each other regarding robotic technology and how we're all utilizing it to help move the field forward.
Okay, this next question comes from Anthony. Are there any advances in using robotics and machine learning to possibly help with spinal cord injury?
Yes. So again, there's no field in medicine that is not where we're not looking at that. With machine learning, we're learning new ways in which we can try and repair the spinal cord, because that's one of the major issues with spinal cord injury is how to get the spinal cord to either repair itself or to provide a conduit around that. There's also new technologies or new techniques with spinal cord stimulation that's being utilized to help with spinal cord recovery following cord injury and things like that. So there are some adjacent technologies that are utilized there. But again, the artificial intelligence and data analysis techniques are also part and parcel to our advancements there.
Our next question is from Katie. How are the robotic surgeries fitting in the ERAS program?
So the ERAS program is our Enhanced Recovery After Surgery program, and that is really it is a kind of package of services that all fit together to help reduce the stress and morbidity associated with surgical procedures. And so robotics is one of the tools that we utilize to make procedures less invasive, which therefore decreases the stress and then also hopefully translates into improved outcomes. So again, it's one of the tools that fit into the ERAS ecosystem to help improve spine care.
Here's another question about replacements. This question comes from Richard. As the population ages, hip and knee replacements have become commonplace. Do you foresee a day when there is a spine or vertebrae replacement surgery? If so, what role might robotics play in that kind of procedure?
So my actual hope is that there'll be a day that spine surgery is not necessary. And so there will be ways in which we can help to restore the spinal column, restore the disc, restore the joints, and then also prevent some of the deterioration that we currently see and that we expect as a part of the aging process. So rather than fixing things that are broken, my hope is that someday we can prevent it from ever breaking.
I'm going to go back to our pre-submitted questions. Are titanium ray-threaded cages still used? Please discuss anterior versus posterior surgical approach.
So, so the ray cages are no longer kind of commonplace. There are other interbody devices that are used. The ray cages, I think, probably in the late 80s were the last time they were used kind of widely. Now they've been replaced by other types of titanium implants, PEEK, which is a type of plastic material, and then also some hybrid technology that has kind of a etching on it to help with bone integration. So it's much more high tech than the old ray cages. Interbody techniques, whether they be anterior, lateral, or posterior, are increasingly commonplace in the spine realm nowadays, because the tools and the different types of implants have gotten so much better, and our ability to access the spine from various portals has gotten better and less morbid. So again, we're able to do that through an inch-long incision versus an incision that used to be stem to stern once upon a time.
Thank you. The next question is, how fast are surgeries faster when using robotics? And how many surgeries can you perform a day?
So at present, I would say the surgeries are not faster just because the robot, again, with any new technology, it takes some time to get used to that. And so it does add time over the traditional techniques, but we've also seen, and the literature supports this, is that as you get more comfortable with it and as the team gets more familiar with it, that time decreases. And so it becomes about as efficient as a traditional case once someone's at their steady state. It varies in terms of the number of cases that you can do and the complexity of the case, because again, some cases that we do are very small, to remove a small tumor or a small disc. And then there are some cases that are complete reconstructions of the spine that can be several hours long. And so it really depends on the complexity of the cases.
Thank you. Is the recovery period adjusted any with using robotic assisted surgeries?
So I would say it's probably less the robot and more the minimally invasive nature of some of the robotic assisted surgeries that translates into the lessened recovery time or the lessened time in the hospital. Again, there's still some controversy around that, so it's not 100%. You have the robot, you're going to be out, running a marathon 3 weeks later or anything like that. But it does show a trend towards decreasing hospitalization time and getting back to recovery faster. And most of that is really attributed to the minimally invasive nature of the procedures.
So one of our guests asked, how did you decide to pursue a career as a neurosurgeon?
I guess I didn't think very long. No, I'm just kidding. Neurosurgery is just very fascinating. The brain and spinal column and the nervous system. It's kind of the last frontier in medicine, and how little we understand about it, and how we're still trying to unlock so many mysteries behind it. That I got interested in college, and then from there spent some time with a neurosurgeon, and it was kind of, as they say, love at first sight, I guess. It was what I wanted to do and how I wanted to spend every day.
Okay, here's another question. Brace yourself for this one. What happens if the robot malfunctions during a surgery?
So that question is the video I showed with the kids, because when technology fails, and I always teach my residents this: you never go to the OR with just plan A. You have plan B, C, D, and E, F, and G if you need it. And so if the robot fails, then you move on to whatever technique or options you have available for you. That's rare for the robot to fail, but again, sometimes your car doesn't start when it did the day before, and so we always have to be prepared for that. And typically we are, and that's kind of a standard part of the way that we approach surgery because of the complexity of the things that we do. We always have our backup plan should we encounter a worst case scenario.
Thank you. One last question. Is there a such thing as remote robotic surgery, surgeon in one city, patient in another, anesthesiologist in another?
Not at present. Again, there may come a day where a surgeon can remotely perform surgery from halfway across the world. But at present, the closest thing to that is some of the technology that's used for, say, prostate surgery or general surgery. The surgeon is in another part of the same room, not across the hospital or anything like that, but in the same room, just physically displaced from the robot and running the robot remotely from a few feet away. So that's the closest thing to that at this point in 2020. But again, at some point in the future, there will be the capability and the technology that will allow us to do that. I may not still be practicing by then, but there will come a day where that will be reality.
Okay, could you answer in 30 seconds or less? Grace Barber is one of our regulars, and she is a high school science teacher and a former ICU nurse. What advice would you give your younger self about your career path? 30 seconds or less.
My younger self about my career path is it's every bit as rewarding as you thought it was going to be. It's every bit as hard as you thought it was going to be, but it's the best thing in the world. Medicine, it has its ups and downs and its trials and tribulations, but if you're in it for the right reasons, and you're in it for the care and being able to help people, it's one of the most rewarding careers that you could ever go into, not just as a physician, but nurses and techs and all the other folks that help us care for patients. The doctors sometimes get the headlines, or we kind of get the name at the top, but it's all the other folks that really make this all happen. And it's a very rewarding field, regardless of what your role is in the delivery of healthcare.
That was an excellent 30-second answer. Thank you so much. And Grace, as always, thank you. Dr. Bagley, we appreciate this enlightening conversation. I think we all learned more about robot-assisted surgery and how it is helping patients, and how that you are prepared with many backup plans. So you will always be able to help your patients during surgery. To all of our guests, thank you so much for joining Science Cafe tonight and for your many questions. And to my public affairs team member, Charlie Thompson, and to Laurie Enright, Rick Press, and Melissa Martin, our O'Donnell Brain Institute colleagues, thank you for helping behind the scenes tonight. Before we adjourn, I just want to remind you about two things. First, we have Science Cafe coming up again on September 22nd with Doctors Jacqueline Albin and Melanie Hafford to talk about lifestyle, surgery, and community, the science and medicine of healthy weight. And we hope that you will join us again on that. Charlie's putting the registration link in the chat. And also, we've got our Health Fest at Redbird next weekend on Saturday from 10 to 2. It's free. We've got food trucks, healthy cooking demos, Mavericks appearances, the Dallas Mavericks. We have speakers. Some of Dr. Bagley's colleagues are going to be speaking. We have a lot of fun, building tours and more. So join us. And as we close out tonight, we wish you all good health and wellness and a good night. Thank you again for joining us. We are adjourned. Charlie, do you want to stop the stream?